from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
We're most pleased to bring you a 2-week series in the field of medicine. Our subject is going to be the problems of backs, and I know many of our viewers, you've experienced this over the years, and we're going to do this in a rather organized way. We have decided in dealing with back problems to talk about both surgery and physical therapy, and we have chosen 2 particular areas that we'd like to address this week and next week. On today's program, we're going to talk about lumbar disc surgery, the problems of a hernia and a rupture, and what that surgery would be about and what the physical therapy would include. And for you who will be with us again next week on the second program, we'll deal with lumbar spinal stenosis, which has a lot to do with arthritis and has to do with surgery, and particularly addressing the problems that senior citizens have in that area. So I hope you will find this program as informative as I believe you will, and that you'll be with us for the 2 weeks. We'll have the same guest on both programs, and we're very fortunate to have 3 guests, and I can testify to the fact that we have experts that can really provide you the kind of information you need. They're very busy, and we're grateful that they would take time to be with us. And I welcome, first of all, the program, Dr. Brett Dirks. He has his offices in Coeur d'Alene, Idaho. He is a surgeon and a specialist on what we're dealing today with. Dr. Dirks, thank you for taking this time, not only today on the program, but the time you spent with me, but in preparing for the program. We appreciate it. And next to him, we have one of our 2 physical therapists today, a man I've known a long time, Lee Shulman, and he has practiced here in Coeur d'Alene for many, many years. In fact, I would say our 2 physical therapists together today have had over 50 years experience. And Mr. Shulman, thank you for being here, and we look forward to your role in the program. And our 3rd guest today is Gary Bartu, who's also a physical therapist and has his offices in Coeur d'Alene, as our other 2 guests do, and he too has practiced for a long time. And Mr. Bartu, we look forward to your answers to our questions. And as always, I'm very pleased to have our regular panelist, Steve Schenck, who is the Dean of College Relations and Development at North Idaho College, and I shall ask Steve to commence our 2 weeks discussion.
Thanks, Tony. I'd be happy to. I thought we'd start today by just trying to get a handle on the scope of the back problem. Is it, and this is just a toss-up to any member of the panel, is it something that a few people unfortunately suffer from, or is this a pretty widespread problem, or problems, I should say? I don't think there's just one back problem we deal with.
Well, I think it's a rather huge problem for the American adult. In fact, statistics would want to tell us that 80% of American adults will have at least one episode of back pain during their lives. So you can see the significant impact of that. And of these episodes, they usually occur during the ages of 30 to 50, which can be a most productive period of most people's lives. Also, we look at the financial impact of that. $70 to $75 billion is spent each year on the diagnosis and treatment of low back pain. In the work environment, we lose approximately 93 million days off work during the course of the year. And so, as you can see, it's a significant issue in terms of productivity in general for the populace.
Let me follow up just a little bit. Gary mentioned low back pain specifically. How does that rate in an entire spectrum of back problems? Is that the most common form of back trouble that you 3 treat?
I think it's more prevalent in the low back than it is up into the thoracic back or into the cervical spine. We have a lot of cervical spine problems that probably are more related directly to injury or to arthritic problems due to the mobility of the cervical spine. But the most unproductiveness comes from the lower back in the lumbar or lumbosacral spine area. When Gary said 80%, that's a tremendous amount. So you can virtually say that everybody is going to have a back problem sometime or another during their period of life.
I'm going to follow up yet again. And Gary mentioned back pain, but I mean, are we talking about a twinge? Are we talking about a little bit of cramping? Are we talking about something serious enough that's going to keep a person home from work for a day or more?
We're talking about the more serious problems that we see with back pain, where it necessitates a person to go in and see their family doctor and necessitate further therapies and diagnostic tools to determine what that's going on. So it's when you're talking about 80%, we're talking about just about everybody. And if it's not you in particular, maybe your spouse or your child or your mother or father or somebody like that.
And since we're already talking to you, what percentage of people, of that 80% of the population that suffers some significant back problem, what percentage of those are going to end up in your office as candidates for surgery?
Probably about 5 to 10%, so a fairly small number.
That's the good news.
That's the very good news.
And I'm going to ask one more kind of a general question, and then we'll go to you, Tony, if that's all right. 80% of the population, are there, and we've already said that most people are going to be between 30 and 50. Are there any other predictors? I mean, is it more likely to be men than women? Is it more likely to be people who are very fit and active and hurt themselves that way, or people who are unfit, overweight, and don't exercise? What's the common profile of a back problem?
I'd like to address it. I think the latter, people who have a low fitness level, who have minimal tolerance in their tissues, if you will, as far as accommodating stress and strain. Those are the people that we tend to see more in our office. People who tend to assume more seated positions than not. People who have to incorporate heavy lifting or excessive loads relative to manual labor in their work. These are people that we usually see with problems.
So exercise with some caution and moderation is a good thing. What about my question about men versus women? Any proclivity there?
I don't think there's any correlation for men versus women, other than maybe men might have a more tendency to have a manual labor job, but in this workforce nowadays, that's not entirely true either. I think that what Gary had to say was exactly right, that it does affect those people that are unfit, they have more of a sedentary lifestyle, etc. But I think that it can affect all walks of life. You can be very fit, you can have a job where you're quite active, and you can be of a low weight, in other words, someone that's not overweight, and still have a back problem and still have a problem that ultimately ends up coming to see me. So
I think what we're seeing is an encouragement for back problems to develop, starting with children in the first grade. They're encouraged to sit all day long, all the way on up to high school. So if you figure out the number of hours they're in a sitting position without physical activity, and some of the schools now are getting more and more away from physical education and not encouraging that, then they go home, they sit in front of the computers, hopefully rather than in front of the television sets. And
except for this show.
Except for this show. But they're encouraged to sit. They're not encouraged to be physically active. Then as they start to grow a little older into their mid-20s, they start to broaden out, and they see the necessity of getting into the gyms and athletic clubs, and so they start that way. But it's something that we need to address, and that is the physical activity of all the people in the country.
They can ride their exercise bike while they watch this program.
Yes, they can.
I'm going to go now to Dr. Dirks, and I've come to your office, and we're going to deal with a very serious problem, let us suppose, and it's going to wind up in surgery. And I know that when a patient comes in, they don't have the diagnosis for you, but to expedite this process, Dr. Dirks, let's say that you're going to make the diagnosis. We are going to have surgery, but as we told our viewers, it's going to deal with lumbar disc surgery. So would you take over and just, for the next few minutes, educate us to that process and the surgery itself?
typically somebody that comes into my office is a referral, and most neurosurgeons, I think, operate in that fashion. So they typically will see their family physician first, who will hopefully make the diagnosis and send it to my office, and then we can make a decision whether or not surgery is indicated or not. Typically the person that comes into my office is in a large amount of pain, because that's usually one of the main presenting complaints for somebody with low back pain and with low back conditions and herniated discs in their back. But other symptoms that can occur are numbness and tingling. You can have weakness, muscle weakness, atrophy, which means loss of muscle mass in the legs. And typically a low back problem means that we're dealing with the lower extremities. And so if we divest ourselves from everything above, I think we're talking about legs and that sort of thing. And then certainly that can be more important is if somebody has loss of bowel and bladder function, and walking can definitely be affected. And going on to what Lee was saying, These people tend to be less active after the low back disorder comes on, so they are more sedentary, so their muscles have a more tendency to have spasm. They have a tendency to have more difficulty in doing the activities that are suggested of them. So let's say somebody comes into my office and the diagnosis of a lumbar herniated disc has been made in the family physician's office, and they come in to see me, and typically they're going to have pain going down their leg. It goes down a sciatic nerve distribution. The word sciatica, that's where that comes from. There's a large nerve that runs down the leg on both sides that is made up from the nerves from the lower back that comes down and feeds into the leg, and so you have pain going down into the leg. And that's probably the most typical problem that somebody comes in to see me. Numbness and tingling is probably second, and what I mean by numbness is somebody that has a loss of sensation somewhere on their leg, and usually in a fairly distinct distribution. And then some people come in with tingling. We call that paresthesias, but that's just a tingling phenomena where the nerves feel like they're kind of waking up, just as if your leg were to go to sleep or something like that, and you were to get up and the leg starts to tingle. And then probably the most important thing to me is if somebody comes in with a muscle weakness, and they come in and they actually have difficulty with moving up and down stairs, difficulty with walking. Their foot may drop down and not walk appropriately or move in the appropriate fashion. So those are the people that are typical that I would see. So then you go through and you do a history. Typical history is, as I've described, you do a physical exam. And these people oftentimes won't have the motor deficit. About, I think, 10 to 20% of the patients I see have some sort of motor deficit. Again, that's muscle weakness. But there are some certain signs and symptoms I'm looking for in my physical exam that's going to point me in the direction of whether or not we have to do surgery or not. Indications for doing surgery can be as something as simple as pain, if somebody has intractable pain. But if somebody comes in with a motor deficit or muscle weakness, then that would certainly point us more in the direction of thinking about doing surgery. So they get through the history and the physical, and then we usually have an MRI, a CT scan, some sort of diagnostic study, some sort of radiological study. And typical of that is an MRI, and that MRI will show us the soft tissues more as opposed to the bony tissues or the bone structure. It'll show us the soft tissues, and the soft tissues would be nerves and muscles and the sac that the nerves are in, the herniated discs if there are any. So suppose then that we have somebody that comes in with a herniated disc on their MRI. The most typical area of that is in the lower lumbar area. So if we go to the model, this is, I would say, one of the unfortunate patients we have. This is actually just a model. So
it's not a real one.
It's not a real one. This is obviously the upper area where the neck is at, the more thoracic area where the chest area, chest wall is at, and then we have the lumbar area, and that's the area we're talking about today. The most typical regions that we have to deal with are the lower lumbar region, and if we number these lower 5 bones, we call them lumbar 1, 2, 3, 4, and 5, all the way down to here, and then we have the sacrum, which attaches to the lumbar region. So if I say to another physician or another person, I say we have a problem at L4, 5, if I go to the lumbar 4 and lumbar 5 region, I'm talking about that disc space there. So it's something I can talk to somebody on a telephone, I can write them a letter, they'll know what I'm talking about.
Uniformly, it's always called
uniformly, it's always called that, and so that if I'm talking to somebody else, they'll know what I'm saying, and they'll know where to go from there. So the most typical levels that are affected are L4, 5 and L5S1. And it must be because of the stressors that are placed at that level with bending motions, side-to-side motions, etc. And the sacrum is fairly fixed because of the pelvis that's surrounding it, whereas the lumbar region has a lot of stressors placed on it. And the thoracic region has less stressors because of the chest wall and the rib cage that's there. And so we typically have that down here in the 4-5 region. So somebody comes into me, and typically they would have an L4, 5 herniated disc, and if you can see that the disc can push in against this nerve is coming out here, we call that a nerve root. If that disc pushes up into there, the nerve is trying to come through this bony structure called a foramen, and that causes pressure on that nerve. Now if that nerve is compressed, it's going to have pain. It's going to have pain until it comes to the point where it's dead. So if somebody comes into me and they no longer have any pain in their leg, but they may have terrible motor weakness or muscle weakness, it may be because the nerve is being pinched so much it can no longer have the pain sensation go down to it.
So the longer you wait, the more damage.
More damage is potential.
Brett, while you got the model there, I know Lee mentioned the cervical spine area. Where that's at
That's
the top.
up in here.
All right, thanks.
So that's what we're talking about up there. And we're talking about the lumbar region, I think, more for the low back problems, and again into the legs. So these nerves, they go together and they form these nerve roots come together and form nerves, and they go into the legs. And that's where we get the word sciatic nerve. These nerve roots go to form the sciatic nerve, and then those other nerves that branch off of the sciatic nerve down into the leg. So typically that person will have a herniated disc push onto the nerve, and then at that point we need to make a decision as to whether or not we're going to have surgery done or whether we're going to continue on with conservative therapy.
We're getting short on time. It goes so fast. But let's say there is surgery. And
Okay.
now tell us what you do.
Okay? So surgically, if somebody comes into me, they've waited an appropriate length of time, and usually I rely on the family physician or the referring physician to help me out in that manner. Usually 4 to 6 weeks of conservative therapy, unless we're dealing with muscle weakness, motor deficit, then we get to surgery. So what do we do? Typically the person will come into the hospital the day of surgery, they'll have the surgery done, spend the night in the hospital, they'll go home the next day.
That quick?
That quick. Typically the surgical incision is fairly small. We're talking about maybe 2 or 3 inches in size. Unless it's a bigger person, more weighty person, then maybe the incision is a little bit larger because of trying to get down through the tissues. It means going in there and kind of trimming off the discs and taking off the portion of the disc that's pushed onto the nerve.
You're not taking the disc out?
We can't take out the whole disc because when we go into the disc, this is huge. And what we're taking out is maybe 30% of this disc. And that's it. Because of the surgery means coming in from behind, moving the muscles out of the way, taking a little piece of the bone out of the way, chip it away, and then take the portion of the disc that's pushing onto the nerve, pulling it away, taking it away.
To release the pressure
To
off the
release
nerve.
the pressure off of the nerve. Leaves about 60 to 70% of the disc left in place. You may have a little bit of disc space narrowing after surgery, but typically not too much. We don't do any fusions. That was kind of the old thing. 20, 30 years ago, people talked about doing fusions in the back. And when we did when the fusions were done, it was thought that that would create a situation in which there would no longer be any back pain. And that wasn't the case. So the person comes in the hospital, they have the surgery done, they go home the next day. I usually see them about a week later, have the stitches to come out, a month later after that. And at that point, I let them do more lifting exercises, and then I think we kind of go into the physical therapy realm.
So most of your patients then wind up in the physical therapist's office?
The younger patients especially,
Yeah.
and that's because they're trying to get back to work. And my
Sure.
older patients, I give them a choice. I say, do you want to do physical therapy or not? And I tell them what we potentially can accomplish, what they can do at home. And I think that I encourage people that are in heavy lifting jobs, heavy equipment operation, mining, logging, the typical jobs we see around here in North Idaho, I typically send them to physical therapy because I think it's very helpful.
Thank you, Steve. This is fascinating, but we only have 10 minutes left to go into physical
Perfect
therapy.
transition, though, because I think we said that 80% of us are going to have back problems. Thankfully, only 5 to 10% are going to need surgery. The rest of us could sure benefit from some advice on what we can do to keep from getting into Dr. Dirks' office. So let's talk for a while. Sorry, we want you to do well, but what can most of us do to lessen our chances of having any back trouble at all, or hopefully or worst from having to have surgery?
I'll go first on that. Being as fit as you can possibly be, being in the very best condition, shape, health as you can possibly be would be very helpful. Having a certain amount of flexibility, muscular strength, and in fact back problems are addressed off the front end with trying to improve stability through the structures. And that means that there's a certain protocol of exercise that can be very, very helpful. That ends up being a very good way to address, following surgical intervention, how one may regain that stability. What typically happens is somebody who progresses to a point where they've exhausted, let's say, conservative care, and they need to see Dr. Dirks, they have gone through a transition of decline. They've lost their ability to stabilize. They go through a surgical process, they have to regroup, they have to build back up. And so being able to incorporate that exercise protocol into their recovery is very, very helpful. Other things quickly, talking about body awareness with that person. How do they move? How do they sit? How do they lift when they're able to start lifting? These are all really important things. What's their posture like? The stresses of posture have a great effect on the spine throughout its entirety. And so having some training on how they need to perform certain functions and be a little more adept at overcoming gravity, because it tends to always win.
It wasn't too many years ago that the standard treatment was for a back problem was to for the physician to send the person home and stay down in bed for 10 days. That basically kept them out of the physician's office for 10 days, and it
A lot of those people got better.
a lot of them got better. But during that period of time, they also lost a lot of muscle mass. And so if they did have to go on and have surgery, in losing that muscle mass, they were not in as good a condition prior to surgery or following surgery as they could have been. And the emphasis now, as it is in so many different types of surgical procedures for physical joints, is that exercise is extremely important. One of the best exercises you can do is walking. And walking is a good way to determine what you're doing. Just placing your hands on your back while you're walking, you can feel the muscles work from one side to the other side. And as this occurs, it helps bring fluid or bring new blood, nutrients into the low back, and help carry off some of the waste products that are produced from the inflammation that's in the area, and assists. And then the home programs, I think, are very beneficial, but they need follow-up. And I'd like to just read to you why I think that. Here's a call from a physician who has spoken to his patient. He makes a call. Hello, Mr. Smith. How's your back pain today? Hi, Dr. Blanpide. It's still kind of sore. How many times did you do the exercises since the last time I saw you? Well, it's been pretty busy at home. I didn't get a chance. I see. Pull out your exercise page and we'll give a go right now. I looked for the paper before I came and I couldn't find it, or before you called and I couldn't find it. This is the usual follow-up to a home program. And that's why Gary and I both emphasize, continued follow-up over a period of time to insist that the person is doing his home program, and it really is beneficial.
And I'll second that. The one thing that I try to get my patients to do is if I can get them to walk after surgery, and even if it's a little bit of walking, if it's an older person or a lot of walking, if I can get them to walk, I'm probably going to be successful with what I've done. I can do the greatest surgery in the world, but if the person doesn't walk after surgery, doesn't do their exercises, doesn't do the things that we've talked about just now, then my surgery is not going to be successful, because that person's not going to go necessarily back to work. And that's part of being successful in doing surgery, is getting people back to work and back to being productive for a lot of different reasons. And one of the reasons why I send my patients to physical therapy, or I tend to, is I think that they have a better tendency to do their exercise if they have to be accountable to somebody. If they only have to be accountable to me on a once a month basis, they're probably not going to do it. And that's just the nature of all of us.
I may be grossly oversimplifying here, but we know we don't want people to be obese. Activity, especially beneficial activities like walking, are important. Does diet play any part in this at all? I'm talking about, aside from the weight loss aspects of it, fluid intakes and an appropriate diet. Does it have any real effect? Maybe we're going to talk more about that in our next episode when we talk about some of the effects of aging, calcium loss, and that sort of thing. But is it a factor at all?
I'd like to address that just briefly. I feel it is a factor, and I think nutritionally people need to be in an understanding mode as to how they can be as healthy as they can be. And given a nutritional status, a person can make a difference in terms of how fast they heal. Say, for instance, somebody who is diabetic, again, some type of nutritional metabolic process that relates. And so if they don't watch a certain diet or a certain way to manage their food intake, that can have a significant detriment on how they heal. And so from a healing standpoint, particularly after a surgical process, people need to understand what they can do and be the best they can be that way.
I hate to interrupt you, but time is so short, and I do want to get one other thing in the program. I don't want to leave, and although we're going back next week, what all of your saying is very valuable. But there's some things that physical therapists do that we haven't talked about, like ice or heat treatments and some medications and so forth. Can I ask the physical therapist, and Lee, we'll start with you this time, what else do you do when you get this patient? And I don't want to underemphasize how essential surgery often is. It has to be done. But now you've got this patient, and before they even get to that point of doing the things like walking, there's very specific exercise from the physical therapist viewpoint that you do. Could you share that with us?
There are specific things, Tony. I think probably more important than the immediately following surgery treatment is immediately following the injury treatment.
Right.
And I'm a firm believer in ice. I tell all of my patients and all of my friends to freeze up a Dixie cup full of ice and keep it in the refrigerator, or in the freezer. And when something happens, ice massage to the area for anywhere from 4 to 6 minutes. Bring it up to a nice pink state, and not take it beyond that so that it's gets blotchy. But ice an injury down. You're never wrong with ice, especially ice the first 24 to 48 hours.
So you and Mr. Bartu both use ice a lot more than you do heat, is that correct?
Initially.
I would say in any injury that tends to want to be of an inflammatory nature, and that's the rule I use. If it stays warm, or if there's a lot of muscle guarding or constant pain, ice is really the way to go. People do better with that.
I got the signal less than 2 minutes ago, and I'm just fascinated with this program. But also there are times when, in your consultation with the physicians, where also medication is used, or there's actually vaccination and so forth for getting rid of inflammatory problems?
I think there's a combination that is very effective, and usually by the time we see the patient on a direct referral from the family physician, they will have started them on muscle relaxants, anti-inflammatories, and something for pain, the 3 different medications. And we encourage the person to take those along with the treatment that we're giving them, and along with the stretching.
So you have medication, you have your treatment, and they're doing home exercises, and they're in consultation with the physician.
Right.
I've been receiving word from our staff that we're out of time. You have been excellent, but the good news to our viewers is you're back next week, and we'll continue this discussion on another kind of surgery with Dr. Dirks. Thank you, gentlemen, very much. Ladies and gentlemen, I do invite you to be back with us next week, and we'll do part 2. And on that program, we're going to talk about lumbar spinal stenosis and surgery there and physical therapy. And we will continue some questions that we didn't get answered today that I'm sure you're very interested in. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station. From the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
I am most pleased to welcome you back to our second program of a 2-week series on back problems, back surgery, and physical therapy for some of those problems. Some of you were not with us last week, I'm sure, and we discussed on that program lumbar disc surgery for rupture and hernia problems in the disc. And we had a very, very informative program, both about the surgery and physical therapy. On today's program, we're going to talk about lumbar spinal stenosis and particularly some of the problems of arthritis as it relates to age. And we're going to talk about surgery again, and we'll talk about physical therapy, both pre and post-surgery. And again, if you were not with us, we are very fortunate to have 3 very qualified persons to discuss something that's very technical but is very common problem for people in society. I first of all welcome to the program Dr. Brett Dirks. He has his office in Coeur d'Alene. He is a surgeon in neurosurgery. And Dr. Dirks, it's a pleasure to have you back. You were most informative, and we look forward to your education of our viewers and us on this question. And I'm pleased to welcome back the 2 physical therapists that we had last week. First of all is Lee Shulman. His offices are in Coeur d'Alene. And next to him is Gary Bartu, who's also in Coeur d'Alene. And I said last week, between you two, we have over 50 years experience. And so we are going to tap that experience here again today. Gentlemen, welcome to the program.
Thank you.
And as always, I'm pleased to have regular panelist Steve Schenck, who is the Dean of College Relations and Development at North Idaho College. And Steve, you can get us into the program again this week.
Thanks, Tony. I'm going to review a little bit. I'm not a teacher, but I'm around Tony enough that I pick up some of the terminology. Last week we talked about back problems in the general population, and we found out that it's a huge problem. It affects approximately 80% of American adults, costs tens of billions of dollars a year in diagnosis and treatment. We're going to talk more about older people and the problems that elderly people have with their backs. And I thought maybe we'd start there. And I'd ask just a real basic and simple question about how do old backs, the question I'm getting more interest in every day, how do old backs differ from young backs, and especially how do old back problems differ from those that younger people experience?
I'll start out on that. In the mature population, what we see are years of perhaps degeneration, years of the effect of inflammation. The bony and supportive structures are not quite as efficient. The spaces between the vertebra, the bones supporting the back, are usually flatter, have lost space, and so we start out with a situation where the structure is a little, sometimes less than adequate, and therefore this condition is easily inflamed, repetitively inflamed, and maybe even chronically inflamed. So that's what we're dealing with.
Lee, in last week's program, one of the things that surprised me was to learn that most of the lower back problems that people experience, they have between the age of 30 and 50. Are we talking about a different kind of back problem this week that the elderly have, or do they just generally have less back problems than younger people do?
No, I think as you age, you see more, but the reason behind it may be different. Rather than from overactive in various types of industry, you see more back problems from underactivity, lack of use, and lack of exercise. And so you lose the flexibility that you normally would have. It's a lot harder to turn and look over your shoulder when you're backing out of the garage in the morning than it used to be 30 years ago. It is 30 years ago. But we see the change in tissue. We're not as strong. We're not, as I said, we're not as flexible. We're not like a car where we can put new tires on every 6 months or a year, depending upon how far we drive. We do continuously repair our bodies. Each cell is exchanged on a routine basis. But it gets old, it gets tired, and it's not as good as it used to be.
Mm-hmm. And Dr. Dirks, one of the things, again, as review, you told us last week was that fortunately most people don't get to the stage where they need to see you and have back surgery. Only about, what was it, 5 to 10%?
A small percentage.
A small percentage. What kinds of procedures are you most likely to perform on elderly patients?
If we go back to the model that we had last week, again, we're talking about the lower lumbar region. We're not talking about the chest wall area, nor are we talking about the neck area. We're talking about the lumbar region and the sacral region, which hooks to the pelvis area. In these patients, throughout life, there's a lot of stressors that are placed on the back, and a lot of us don't always realize this, but we have a lot of joints in our back. It's just like the knee joint or the elbow joint or some other portion of the body that has a joint. There's joints at every one of these bones here in the back. And as we go through life, we do a lot of bending, twisting, and then depending on what kind of things we do with our jobs and our activities for pleasure, etc., these joints take a lot of stress. And throughout time, as we do more motion side to side, etc., we get hypertrophy of the joints, which means an enlargement of the joints. And by enlarging those joints and creating situations which we call degenerative arthritis, and those are big words, they don't mean a whole lot. Degenerative just means that there's a degeneration or a loss of function of that particular area. Arthritis just means inflammation of the joint. So we have a degenerative arthritis in that joint that causes hypertrophy, it causes enlargement of that area. And if you think about it, when you're looking at the spine, the area where the nerves come through have to come through a hole about like that. But as these joints get larger around there, that creates a situation which the hole gets a lot smaller for where the nerves have to go down through in the portion of the spine here. When we get that situation, we call that stenosis. So stenosis means a closing down of a previously open space. And it's on a chronic basis. So we tend to deal with more of the older population when we talk about lumbar spinal stenosis. And in these patients, they come to me with complaints of pain going down into their legs. And the reason for that, as we talked about in the last program, the nerve roots that come out of the back, they come in and they form the nerves that go down into the legs. So if those nerve roots are being compressed and being tightened around, or stenotic, or stenosis, then we have a situation in which the nerves start to hurt and they cause pain to go into the legs. So the typical patient is somebody that's about 60 or 70 years old. They come into my office, they've been screened by their family doctor, family physician, and they've been found to have some degenerative arthritis in their back. And they come into me and they say, I used to be able to walk 2 miles a week or 2 miles a day. No problem, doc. And I say, wow, how are you doing now? I walk about 2 blocks and my legs start hurting. What do you do? Well, I sit down and it gets better. Then I get up and I walk another 2 blocks and my legs hurt again. They sit down for a couple of minutes, the legs feel better. So standing or walking tends to aggravate the problem. And there's a lot of theories about that. I think probably the more common thoughts are that there's a decrease in the amount of blood flow to those nerves because of the tightness around the nerves as they try to get through that tightened area in the spine that we see there. And so these people come into me and they complain of walking pain. Now, there's a lot of things that cause walking pain, so we don't want to misinform the viewers that just because they have leg pains that they have a problem in their back. They may have something wrong with their blood vessels in their leg, and there's a lot of other things that can be going on. So certainly the family physician is the person that we need to talk with and gain some understanding as to where we should head from here.
I want to interject here if I can, and if we can, as we're doing this, if we can go through surgery again,
Okay.
Doctor, concerning this particular problem. If you maybe want to use the model again,
Okay.
we will show our viewers like we did last week, although this is a different kind of surgery, and if you would explain why it would be different and how you would perform that surgery.
Person would come into the hospital the day of surgery, they'd have the surgery done. The surgery entails making an incision on the back where the area of the stenosis is, the tightness.
Where the tightness and closing.
The tightness and the closing area.
And is that usually in one particular locality, or is it usually up and down?
Usually 1 to 2 or 3 different levels.
Okay.
I mean, I've seen people have it all the way up and down their spine, and that becomes more difficult.
So then you'd have to perform surgery in that whole area then?
You'd perform surgery in the area where there's the stenosis or the tightness.
Okay.
And you'd make an incision. Keep in mind that there's fat, there's skin, and there's some fat, and then there's muscles down in here. So the area is maybe that thick, even on a skinny person, from where you actually make the incision. The skin doesn't sit right on top of these bones. Even though you feel those bones, there's still a fair distance in most people.
If a person's very heavy, then it's much larger?
Much larger. You know, you might be talking that much distance.
Do you ever consider, if they can afford it, to let them lose some weight before surgery?
Have you ever tried to lose weight? You don't get people to do it very often.
Some of us have an easier time.
There you go.
I'm bragging because I've been losing weight.
So then you get in there, and what you want to do is you want to take off these bones that are in the back there. And you want to take off a portion of the bone. You want to take off what we call, if you think of the area where the nerves are coming in, this is kind of the roof, these are kind of the walls, and these are kind of the floor. What we're going to do is we're going to take off the roof. And so you open things up like that. And so essentially what you're doing is you're taking off the roof, which is the back part of the spine, or the posterior aspect of the spine. And by taking that off of there, that leaves it in a situation which is now open. The nerves can get through there, and there's no longer that stenosis.
And when you open that up, will that stay open, or will there ever chance of closing again?
If most likely it won't close again. We've had some patients who come back 10, 15 years later that might have a closure over, or they might have a focal area or a small area that's stenotic.
You're so good at communicating. I can see where that would just relieve all the pain. And then we're going to come back with Steve and the physical therapist in a little while. Now there's the opportunity to do some things that they couldn't do before. My suspicion from hearing what you're going to say, that you could pick up the walking again and so forth, and if you can do more exercise, and then you can get in better shape.
What it can do for the patients is change their whole life. And I'm not saying that this is a panacea, a fountain of youth. I'm not saying that at all. What I am saying is that people that have this particular problem, if they come in to see me and they're having the leg pain, then surgery can very much benefit them, so that after surgery they're able to walk the distances that they would like to. And I typically tell my older patients, keep it to a mile or two. There's no reason to walk more than a mile or two unless they have some specific goal in mind. But in general, they'll be able to walk a mile or two without too much problem.
And they can build over time.
And they can build that up over time.
I have one other area I want to get into, and then I am going to go back to Steve. You good people are used to these terms all the time, and we lay persons get lost and sometimes, but you've done a great job of not losing us. But we talked earlier about there's so many things, Dr. Dirks, that you're doing now that you could not do because of lack of technology. X-rays wouldn't show up certain problems in the muscle and so forth. Would you take us a little bit through the terms we hear all the time, CAT scans and MRIs, and what you find out, and does that determine that it's easier to know if we are going to have surgery?
It makes the diagnosis much easier.
And maybe even more accurate in the surgery itself?
The words CAT scan, what that means is that there's a situation in which we can make pictures of specific areas in the spine that are very detailed. And we can do that up in the head. We hear about head CAT scans or head CTs, and I deal with that all the time as well. But we can do that in the spine. And then probably more importantly is the MRI. That's magnetic resonance imaging. That's all
what
MRI
makes it
means.
different from a CAT scan?
MRI is much better because it can show us what the soft tissues look like, what the nerves are, what these discs are. And keep in mind, these discs that are between the bones, they're like shock absorbers. Okay. And they're very soft, or they can be soft, and they have usually an area around them that is fibrous, and then an inner portion, which is the part that herniates out, or disc ruptures, which we talked about last week. But that situation, these shock absorbers are soft, and so they don't show up as well on the CAT scan. And so we typically use the MRI for that, and I think it's very helpful.
Thank you.
Tony, I might put a plug in for KMC on that. They just recently,
for our viewers in other states, that's Kootenai Medical Center.
Kootenai Medical Center. They just improved their MRI capability with addition of some new equipment to go along with it. So the imaging is not only great, it's even better than that.
And actually, where I trained out in Iowa, at the University of Iowa, which was the largest teaching hospital in the country, and the MRI quality that we have here in Coeur d'Alene is probably better than anything they have back in Iowa and what I've seen in other places. So we're very fortunate here in North Idaho.
That is impressive, and therefore you know more what you want to do and can do.
That's right.
Steve?
Brett, the degenerative arthritis that you talked about that leads to the problem of stenosis, is that a natural consequence of aging, or is that something that shouldn't happen but does to people who don't behave themselves when they're younger?
I tell all my patients when they come through the door, I tell them that degenerative arthritis, and everybody looks at me and they roll their eyes and say, I'm getting old. And I say, yeah, you are getting old. But that's part of the way things are. People age in different fashions. They age in different rates. And some people have more degenerative arthritis at age 55 than somebody that's at age 75. But I also tell my patients that if you live long enough, you're going to have some form of degenerative arthritis. So if you get to be 90 or 95 or 105 or whatever, you're going to have a fair amount of degenerative arthritis. Some of the things that physical therapists can help us with, though, is we're talking about the stabilization of the spine, help with the muscles, help to create a situation in which there's stability in the spine so we don't have all these other problems that can happen with old age.
Well, that's another perfect transition. I think this happened in our last show because I wanted to move to a discussion of things that elderly people can do to minimize the consequences that you're talking about. And particularly I wanted to visit a little bit about exercise and some specific kinds of exercise. It's pretty generally known that another inevitable consequence of aging is loss of muscle mass and loss of bone density. What can older people do to at least, maybe you can't stop that entirely, but what can they do to retard those things from happening?
Well, I think what you have to first look at there is the flexibility as we age. And as we age, I'm talking about from mid-20s on up, because we reach our maximum growth, somewhere in the 20s. And the insistence on stretching programs to maintain that flexibility and to some degree the strength. We have become a nation of cream puffs, actually, strength-wise. There are a lot of people who use the athletic clubs and gyms and that, but for exercising. But we don't walk anymore. We jump in a car and we drive across the street, or we drive down to the grocery store. The grocery stores aren't mom and pops on the corners anymore, so we don't carry our groceries home. We sit around, we develop too large abdomens, we put too much stress across on our low back, and consequently create problems that we don't take care of until we start to develop the back pain. And again, I emphasized last week that as we put persons on exercise programs for home, they very seldom carry them out. So what we try to do is keep them on a short stretching program, short flexibility program, so that in 2 to 3 minutes in the morning, 2 to 3 minutes before an activity, or even less, they can maintain some of that flexibility and really help themselves and not injuring themselves through the various types of activity.
Yeah, beyond the stretching and flexibility, muscular fitness is really a key issue. And as what you alluded to, Steve, in terms of bone density and the loss of lean body mass, as we mature, as we age, most studies now are indicating that yes, we can delay this process. And so people who have, whether they've undergone a surgical procedure or if they're trying to delay the inevitable, they can be involved with a strength training program using light weights under certain specific guidance. They can get involved with pool exercise, which now is very apt at incorporating resistance training without the impact. And so you can get the best of both worlds. You can have certain flexibility, improved strength, and without the impact. And for the aging population, that's pretty significant because their tissues are a little more fragile. Addressing the issue also that Dr. Dirks indicated, these people, after they have surgery and they have this release of this pressure, it's like a new world for them. And so now they are able to be more active. Now they are able to stand up and be a little more comfortable. Whereas before they were relegated to sitting for comfort, which again is a form of inactivity. So we try and encourage them to be as active as possible, and as Lee mentioned, with the use of athletic clubs, having a pool, having a light weight training program is very, very helpful.
And as Dr. Dirks had mentioned, walking is something that everybody can do, even if it's just out to the mailbox and back and then down to the corner and then up to a mile a day is extremely important. And I think another thing that we need to look at is the endurance. We may be very, very strong, but if you don't have any endurance, that doesn't help. So we try to incorporate all of the different areas from strength training to improve your endurance so that you're able to do more things.
Maybe one final word also is, as we talked last week, teaching this population how to protect themselves with correct postures, teaching them how to move and be aware of how they're moving is really helpful. A lot of patients that come in may want to be involved with yard work or gardening, and so instructing them in certain ways that they can minimize trauma to their tissue ends up being very helpful information. Rather than just a set group of exercises, we want to apply that functionally. And I think that's really critical for them to get that word, and that's where physical therapy can be very helpful.
In our country, we build things to the average. So for me to, for instance, just brush my teeth in the morning is a lot different than somebody who's 6'7" standing at the same wash basin trying to brush their teeth. But there are ways of placing your feet, you know, and stabilizing the pelvis so that you can go ahead and do those things. Those are some of the things we do in our training.
One of the purposes of this program is not only to inform our viewers about subjects, but to help them with things they can do. And I know when I met with Dr. Dirks, he had a wonderful manual for this lay person who didn't know what he was doing concerning this subject. And then when I met with Gary Bartu, he gave me some pamphlets, and then Lee Shulman showed me some he had. And what I'd like to do now for our viewers for just a moment, I would like to, and then get you to react to it. These are manuals, and as a matter of fact, I believe you call this patient education as part of it. The first manual I'd show you is called Back Owner's Manual, and this is it right here. And again, Dr. Dirks gave me this, and I went through it, and it has not only a description of the back and the problems, but what can cause those problems and surgery and treatment. Then the second one I have is called Back Pain, How to Control a Nagging Backache, and this is what it looks like, and I thank you for that pamphlet. And then the third one is called The Fit Back Workout, Stretching, Strengthening, Charting Your Progress, and this is what it looks like. And I know in the surgeon's office and in the physical therapist, these are available. Would you like to react to that?
The AARP has a pamphlet out. I don't have any with me, but they have a pamphlet out that talks about some low-impact exercises that can be done. And I don't know how to get a hold of them other than just to call their local phone number, and I'm sure they can get pamphlets for you and show you some nice things, show some exercise that might be helpful.
Good. And Lee, can I come to you and look at your chart? You have a chart for your patients, you know.
We do.
Would you kind of share with them the kind of things that you want them to do? And I would assume, after what you read, them to go under your supervision, because there's ways to encourage them to do this on a daily basis.
There are, and what we like to do is be specific to the particular problem that a person has. You know, you take in consideration their size, their weight, and their age, and their ability or inability to do certain things. So what we do is we develop, and I know Gary does this too, develop a specific program for a specific person. Not that somebody else couldn't go ahead and do that either.
In addition, if I can interrupt, not only to their age and their weight and so forth, but also the kind of problem they have.
Certainly, whether it's an arthritic problem, whether it's a post-laminectomy or a disc problem that hasn't been taken care of yet, these different things that we look at, and we really try to encourage the exercise program to be as short and simple as possible.
Each session?
Each session.
Do you recommend every day or every other day, or does that depend on the patient?
It depends upon the patient, but I recommend at least morning and evening, and if they can work out a program for 2 more times through the day, a stretching program which takes 30 seconds to a minute and a half, depending upon what you're having them do.
So you're not talking about a lot of time.
Not a lot of time.
Like brushing your teeth.
That's correct. And again, you know, referring to what I said earlier in the program about a person will not carry out a home program unless it's short. And the shorter, the better, the more likely are carried out.
Now, we can't do all the subjects we want to in 1 year, but next year I want to come back and talk about helping people show them certain exercises. I do want to go to Mr. Bartu, and I'll come back to Dr. Dirks, but if you get on a regular routine, and I'm speaking even more of 2 minutes, but a regular exercise, maybe even under a trainer, some of us have a higher metabolism rate than others, and We don't have so much weight problem. And I experienced, I'm being personal, Steve, but I got on to an exercise training process, and what I suspect has happened without going to a physician is that it's triggered my metabolism rate faster. Is that possible? I'm not having trouble losing. I wasn't really overweight very much, but I have lost 11 pounds in a very short period of time.
Right.
And is that because it's triggered that rate again?
Yes, it has. And simply stated, because you're involving your muscles in that process of tuning up and getting stronger, your muscles have become more efficient at what they do, and so they need fuels, and they would rather have fat at rest than sugars. And so therefore you're a more efficient machine metabolically, and by training your muscular fitness, by improving your muscular masses, your chances of improving your physical stature, your strength, your stability, and your ability to burn fat is heightened.
My machine isn't as good as yours, and I found 11 pounds.
I gave it to you, right?
One point to make, a lot of where the viewers are, they live in towns that have malls.
Yes.
And the malls open up early. And they open up usually, I think Silver Lake Mall opens up about 6:30 or 7 and lets people to come in and do their walking. And so we have harsh winters here, but people can get out and they can go to the malls. I know down in Moscow
Or
they have
Canada.
That's right. They have the Edmonton Mall, and they have the Plus Empire Mall down in Moscow, and et cetera. Or you can go to your local grocery store. The grocery store is big. I'm sure they'll be happy to have everybody walking around. But you can get a fairly good exercise for 10 or 15, 20 minutes.
And so what we're saying is if you lose weight, you have less chance of high blood pressure or heart attack, but also something we want to get in again before the time is up is you increase the chances of not having an injury because you're more fit. One other thing, I guess we have about a minute and a half left, and maybe I'll go to you, Dr. Dirks, on this. I saw in these pamphlets that also stress can be a great problem, and so would you address that in about a minute?
What I would say about stress is this. Basically, if you exercise, your body has a better ability and is adapting a better ability to adapt to stress, and is better able to handle that. And if I can do one thing, and that's talk my patients into walking, that will create a situation which it helps to strengthen up their back, it strengthens up their body, and gives them a better mental attitude about their life.
On that note, I have to bring the permanent conclusion. Gentlemen, on behalf of Steve Shink and our staff, we thank you for being here for 2 weeks. It's been most informative, and I hope you'll come back in the future and share with our viewers again. Thank you very much. Ladies and gentlemen, I'm sure you have found this most informative, and I'd like to invite you to be with us again next week when we will discuss yet another issue. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.